Okay.
All right, thank you, Karen. So good afternoon, everyone. Welcome to the 7th Rules Advisory Committee meeting for House Bill 3046. My name is Brooke Hall, and I'm a Senior Health Policy Analyst with the Division of Financial Regulation. You all should have received an agenda and additional materials via email. And I think, Karen, you said you were going to pull up that agenda. I just wanted to mention at the onset, at the last RAC meeting, I know we had mentioned we were hoping to have draft rules available for review today, but it became clear that we needed to have some additional conversations before presenting draft rules. So today on the agenda, we have additional conversations regarding Section 8 of HB 3046, which deals with utilization review criteria and level of care placement decisions. We'll have a brief conversation on Section 6, which discusses network adequacy, and then another very brief conversation providing updates and answering any questions on the reporting that is due on April 1st. And our next RAC meeting is, I think, 2 or 3 weeks away. It's in April 14th, I believe. And I do expect to have either draft rules or an outline, something to share to discuss during that RAC meeting. So with that, first I'd like to ask those who submitted formal comments to summarize those comments. And we did receive formal comments from NAMI and also from Representative Nose. So Chris, why don't we start with you if you're on the line?
I am here. Thank you. I'll be brief. I mean, the comments are extensive, and I don't think I need to summarize them in detail, but it does go to Section 8, in particular, paragraph 5 and other related paragraphs. This is the language around level of placement and making sure absolutely clear that the plain text reading of the legislation is that it's the tools identified as being associated with the nonprofit associations for those clinical specialties are the tools to be used for level of placement determination. Expressed desire for the division to provide clarity that additional utilization review criteria that is permitted in paragraph 5AC can't be used to layer on top of that to make adverse decisions or to water down the requirements in level of placement language. Forgive me, I'm off of spring break, so my brain is not, it's a little bit still on the Oregon coast. Specifying in rule so that there's not vagueness, what are the current instruments that meet the criteria of being part of those nonprofit associations. Since there are no other instruments out there right now, it seems to me that's an easy thing to specify. It would allow conversation in the future as things evolve or as other tools come forward that could be revisited in rule. Making sure that there's some reporting associated with this, so there is some quality check that not only are these level of placement criteria being used, but they're being used as intended. And we provided, I think, some example language, making sure that other criteria used that is permissible under the legislation actually meets the definition of generally accepted standards of care, and also that other criteria is disclosed. So there is a caveat in the legislation around copyright protection that is not used haphazardly, and that when necessary, there is a process to appeal such a decision to the division. I mean, the idea being that we're all better off if we're able to all examine and see the songbook that we're singing off of when it comes to these criteria for our particular carrier. Making sure that other criteria isn't derivative, that it actually meets the definition of generally accepted standards of care, that it be based on that, and that we probably do that prior to usage, so we're not on the back end having extensive disputes over the validity of that criteria. We pointed to some work being done in New York that allows that to take place in what we consider a fairly efficient manner. So again, that we're all in agreement. And then making sure that when it comes to one of the generally accepted standards of care, erring on the side of caution, suggesting some language that it fits with the legislation itself, making sure that people have access to the level of care necessary, and if that's not available, that level of care, it can't be judged not available just because it's not in network or not local, and that somehow the higher placement of care be used to avoid of out-of-network placement. Making sure, again, putting in place those things that get people to the proper level of care versus being moved into different levels of care that may not be appropriate. And then specifying some of the information we think ought to be specific in denial disclosures. And I think that does it.
All right, thanks, Chris, for that summary. And again, these were included via email, I believe, both NAMI's and Representative Nose's comments. So I know Representative Nose has joined us in the past. I don't see him on the line now, but just is Representative Nose or someone from his office on the line that could provide a summary of his comments?
Yeah, I can. I don't want to repeat too much or go in the same areas, Chris, but I can just briefly say that I think one area of focus was on clarifying Rep. Nose's intent on level of care placement criteria, specifically about nonprofits being able to develop this criteria, but not necessarily that applying to carriers developing in-house or criteria or third-party criteria outside of the narrow definition. But I don't want to go too much in depth, but I just wanted to clarify that point. Thanks.
All right. Thank you. And thank you to everyone who submitted comments. They really are helpful for us when we're trying to, think some of these things through and try to draft rules. So, all right, next, let's move on to a discussion regarding Section 8 of the bill. And Karen, if you can pull up the bill, I think there's some highlighted sections. I wanted to have a discussion. We did have a brief discussion about Section 8 at the last RAC meeting, but that discussion was cut short due to time. And I think there are additional areas of this section that warrant some conversation before rules are drafted. I thought we would start by discussing some of the definitions that may need further discussion found in Section 8. And Karen, if you've scrolled down, I think I highlighted those definitions in Section 8. The first one should be generally accepted standards of care. It's a long bill, a lot of scrolling.
I believe what you're looking for is on page 6 of the bill. It's not.
There's another. There is a definition in Section 8. I think there is one on page 6, and there is one on page 14 as well. Yep, there we go. All right, so here is the definition that's highlighted on your screen. The first one, generally accepted standards of care. You can see the definition there. I'm not going to read it out for you unless you all want me to. If you do, let me know. My first question here is there anything else we should consider when defining this term, or is the definition that's included here in the bill sufficient? And is the screen large enough for everyone to read this, or do we need to make it a little bigger? Good, okay. Does anyone have any thoughts on this definition?
Hi, this is Dan Thoma. I think that's a pretty good definition.
Great, thanks, Dan. And Melissa?
Yeah, my only thought, it's not really about what's there, but maybe about what isn't there. One of the things that, and I'm representing OIMHP, that we're concerned about is sort of the difference between clinical versus statistical when it comes to determining generally accepted standards of care. And it seems like, you know, here there's a lot of focus on clinical guidelines and things that are clinically appropriate. And one of the concerns that we have about some of the third-party company monitoring that we've been actually seeing around the state is that they seem to be using statistical methods to monitor, and that might need some clarification.
Thank you, Melissa. Any other thoughts on this definition? All right, let's move on to the next definition. Karen, if you scroll down a little, I think it's on the next page. The next definition I have highlighted is valid evidence-based sources. Again, it's highlighted on your screen, so feel free to read it. I know that in some of the comments that we've received on this section in the past, some of the evidence-based sources have been kind of defined for us, but I'm curious if there are any, or what evidence-based sources are currently being utilized when defining criteria. Is there evidence-based sources that, you know, are the go-to, or are, you know, is there something that is generally used when defining criteria? I thought I heard someone start talking. All right, so same question as the last. So is there anything else we need to think about when defining this in rule? Or is the definition here sufficient? Right, I'm not hearing anything, so I'm going to assume this is considered sufficient and nobody has any other thoughts about it. So we can move on to some of the other sections of the bill. I wanted to move on to section 5AB. So Karen, if you scroll down, I don't think I have it highlighted, but if you scroll down, 5AB should be there. And this section outlines the criteria that must be utilized when making level of care placement decisions.
You want section 5? So that's...
I'm sorry, section 8, subsection 5,
okay.
AB. Okay. So I think if you go up.
Okay, here's 3, 4.
There we go, 5. Yes. Okay. Thank you. All right, so this section, again, this section outlines the criteria that must be utilized when making level of care placement decisions. I know some of the comments we have received have outlined the current nonprofit associations that provide guidelines. I know the ones that have been listed in comments are the ASAM criteria from the American Society of Addiction Medicine, the level of care utilization system, or LOCUS, by the American Association for Community Psychiatry, the CAL LOCUS by the American Association for Community Psychiatry, and the Early Child Service Intensity Instrument by the American Academy of Child and Adolescent Psychiatry. Those are the nonprofit association guidelines that have been identified in previous comments. So my first question is, are there any other nonprofit guidelines outside of those that I just listed that are currently utilized in level of care placement decisions, or guidelines that should be utilized in level of care placement decisions?
So those are the only ones that I'm familiar with, and those are the ones that we intend to use. I do not support spelling those out in rule.
Okay.
The facts on the ground may change, and I think that rule needs to be flexible enough that the rule doesn't need to be amended if some other guideline becomes the accepted guideline, or if another professional association that meets all of those criteria should issue guidelines.
Thank you for that. Gary?
Yeah, piggyback on Dan a little bit. This is Gary Holly, Pacific Source Health Plans. Don't we have to specify a addition or a little bit, be more specific if we do refer to an associations, Dan, instead of leaving it very open? Because you could almost say that the association is going to write the rules then. We did this with mental health where we had to come down to a specific edition and year is what I recall, as opposed to leaving it broad and saying if this association, whatever their criteria are. And I thought we had to be a little more specific. That's why we had to put this in rule and call them out. Brooke, do you know?
Cassie, do you? I don't actually. Cassie, do you have thoughts on that? I know you're a little more familiar with rulemaking and the process than I am.
I think we can discuss it. I don't know if I have an answer for you, Gary, today, but I know in other rules that we do have, we have the DSM, the specified DSM that you should be referring to. I don't, a thought on that. I don't know how often these guidelines are updated, and someone might be able to provide some more clarity on that. But we could put some language around the the most current, generally accepted standards of care as a way of being flexible if it does update, so we don't have to go into the rule continuously, but open to hearing thoughts if it's better to be more specific with this. And I see that Jen's hand is raised. So Jen, do you have any comments on this?
Yeah, I do. Thank you. Jennifer Baker with Providence Health Plan. And I would kind of just concur with what both Dan and Gary have been saying. I think there's I have a couple of thoughts, but in reviewing Representative Nose's comments, it does specifically say level care placement was specifically separated out to maintain its connection with the court decision in WIT. But as we all probably know, the WIT decision was overturned last Wednesday. And so my comment is this is unsettled law. It is not clear where it's going to go. We're not adverse to ASAM or LOCUS and those standards, but what we want is and I think what everybody wants is some consistency. And so being too specific, I think, could lead us in a direction that may not make sense later on down the road. So I would agree, let's leave it out in terms of the level of specificity on it until we know more.
Okay. Thanks for that, Jen. And I think there's Chris and then Tim. So why don't you, Chris?
Yeah, great. Thank you. One, the WIT decision being overturned is immaterial. This is state law now. Two is, in rule, the language we suggest is that these instruments are considered compliant. They're not a mandate. It doesn't say they're the only thing that can be used in our suggested language, but it does affirmatively state these instruments are compliant with the legislation and definition. So I disagree that somehow putting in a rule is going to tie people's hands, and we update rules all the times as well. But did want to point out in our language, it is not mandated that these are the instruments.
Okay. Thank you, Chris. Tim?
Yeah, I was just going to echoing what Chris said, is that, yeah, I mean, yes, WIT was overturned, but this law was enacted partially so WIT doesn't matter. So it's state law. It's a statute now. So whatever happened with WIT, even if Representative Nose's rationale referenced the WIT standards, those WIT standards still exist. A court just overturned them, and this codified them into law. So that has no bearing on anything. The fact that WIT was overturned.
Thank you, Tim. And Dan?
Thanks, Chris, for that clarification. I didn't catch that your suggested language was just to say that they would be compliant. I was reading that as that those would be the mandated ones. I don't object to language and rule saying that they would be compliant as long as that doesn't rule out the use of other standards that meet the criteria.
And I would just back up, Dan, really quickly on that to say, if you're going to put it in, use permissive language as opposed to mandated language, because that's not the requirement.
Thank you, Jen. Thank you, Dan. And I still see your hands up, Tim. Is that from the previous conversation, or do you have something to add?
No, sorry.
That's okay. All right. So also, in this section, it does talk quite a lot about the generally accepted standards of care. That criteria needs to be developed in accordance with generally accepted standards of care. So for level of care placement decisions and other utilization criteria, how are insurers currently determining that criteria is developed on generally accepted standards of care? Is there a current process for that? And if so, what does it look like? This is just for me to have a better understanding. Does anybody have any thoughts on that? Go ahead, Dan.
Since nobody else jumped in on that one. So I can, of course, only speak for MODA and what our process is, but we have a process that applies equally for medical and for behavioral health services. We have a medical necessity criteria committee that that reviews and approves all of our proposed medical necessity criteria. And so, for some services, we use MCG guidelines, and basically we don't use those for behavioral health because we thought our own were better. But the process is it's a review of the literature by people with subject matter expertise, and then that language gets proposed to our medical necessity committee. We often will have external either specialists or entities review those criteria and give us feedback on them. And then we update them every year. We take a fresh look at the literature, say, has anything changed? Have any regulatory requirements changed? Do we, have we learned anything from use of these criteria where we find that part of that might not have been appropriate? And we just keep updating them, typically on an annual basis that way.
Thank you, Dan.
Yeah. Clarifying question from me. What is MCG?
Sorry, that used to be called Milliman Care Guidelines, and then they sold themselves, or they were purchased by another company, and so they had to drop the name Milliman.
Is it standard practice for other insurers to update those annually as well? Or is there a different process based on the provider?
This is Jennifer with Providence Health Plan, and I would say it is standard to update, but I mean, I think all insurers do things slightly differently. Micromanaging how we do it is not probably the answer, but I will say that we do have a robust medical policy and do plenty of ongoing review. So,
yeah, this is Gary, Pacific Source. We're the same. I want to say we do it more, more often than annually, but I can't for sure say that, but I know at least annually. Maybe we look at it, if not more frequent.
Right. All right, are there any other thoughts on that particular section, 5AB? I think, Karen, if you go up a little, that's the 5AB.
Yeah, this is Dan again. So the letter from the coalition suggested that they should be submitted for pre-approval, and I would not support that. I think that is too clunky. And I also am not convinced that the division has the expertise to review the contents of medical necessity criteria.
I would add, I would agree.
Go ahead, Jen.
Sorry, say that we really don't want to see these rules go beyond the boundaries of the statute that are provided, because I think that will create just more litigation and contention. So let's keep within the boundaries of the language.
Thank you, Jen. All right, so moving on to section 5AC, that is on your screen right now. And this section outlines the criteria and guidelines that can be used in medical necessity, utilization, or other clinical reviews that do not involve level of care placement decisions. And it also requires insurers to make the criteria and guidelines publicly available upon request to the extent possible by copyright laws. My questions are really around the copyright laws because that's not a process that I am familiar with. So my first question is, what's the current process for making sure this information is publicly available, if there is one?
Chris, did you have something you wanted to add on the last one?
No, I'm fiddling with control. You mean the last section we were talking about?
Yeah, okay. I just saw your hand was up. So.
Yeah, well, and yeah, that's user error.
Okay.
I apologize if I overlooked you, Chris. You're welcome to jump in if you have comments about it.
So yeah, I can speak to the copyright thing. Because I had asked to have that included in the statute. And first, I want to make clear that the intention behind asking that be included had nothing to do with hiding anything or making information difficult to obtain. I just wanted us to be not in a position where we were required to do something that was violation of our contract with folks that we may license material from. And so for us, that for MOTA, that really is MCG guidelines that are protected by copyright. And so my understanding of that is we are not allowed to make that information generally publicly available. However, we are allowed to comply with the ERISA requirements that are detailed in the coalition's letter, that when we issue a denial, we're required to make those specific guidelines available. And again, that really doesn't apply for me on the behavioral health side so much, because for the most part, we don't use the MCG guidelines for behavioral health, and our behavioral health criteria are currently available on our public website. Anybody in this room or anybody anywhere across the world can look them up and find them. But the intent of having that language in there really was to say that, you know, if our contractual agreement with MCG or somebody else's contractual agreement with Interqual or whatever it is prohibits them from making that information generally publicly available, we just didn't want statute to put us in a bind in that respect.
All right, thank you, Dan. Does anyone else have thoughts? I have a follow-up question, which is when there is a copyright claim and an insurer is not able to release that information, is there an appeals process that an insured could utilize?
I don't know the answer to that.
Okay.
What do you think, Brooke? Appeals through who?
Well, through, like, yeah, if the insured wanted to have those criteria or guidelines released and the insurer said they could not do it due to a copyright claim, could the insured then submit some kind of appeal to have it further reviewed to see if their criteria or guidelines could be released? I hope that makes sense.
The releasing of it, I think, is the concern.
Mm-hmm.
You know, I would envision if we had to, we could send those to an IRO or an external review. But I don't know if our member could actually appeal to us for access to it. It's probably more of a legal question than what I would know.
Okay.
Sorry.
That's very helpful. Thank you. All right. Does anybody have any additional thoughts on this section 5AC?
I think, Brooke, this is Chris. I think the issue is making sure that someone's not erroneously claiming copyright or fabricating some manner. So again, our comments are really aimed at closing a possibility of a bad actor creating their own in-house criteria and saying it's copywritten and no third party putting eyes on it, such as the division, to say, you know, hey, that's a spurious claim of copyright.
Okay. Thank you for that. Let's see, I see some hands up. Let's go Tasha and then Melissa.
I will defer to Melissa first because I think her hand was up first.
All right, Melissa, go ahead. Thank you, Tasha.
Yeah, I actually have a question, and I think that, you know, there's been a couple of previous mentions to this specific section, and the question that I have is, you know, now that we've established that other, you know, as written, other criteria and guidelines may be utilized if such criteria and guidelines are based on current and generally accepted standards of care, et cetera, how are we supposed to know that whatever criteria are being used are actually in compliance? Like the way that you know, we support what NAMI has said about demonstrating prior to usage that the criteria are in compliance, because if we don't do that, then we're back into this sort of reactive place, which was part of the problem, which was a big problem with parity, enforcing parity in the past, is we're reacting to situations where we don't think they're in compliance, rather than saying, hey, let's proactively make sure that they're in compliance before they're put into practice. And so that's my question, is how do we know that these other criteria and guidelines are in fact in compliance?
Thank you, Melissa. That was actually one of my questions when we moved on to section 5 little b. So I would put that out to the group as to, you know, is there a current process for demonstrating that criteria are based on generally accepted standards of care? And if so, what does that process look like?
So, Brooke, I think I might be able to kind of start to speak to this, and I would reference the federal, the report that was recently released to Congress, and the findings of that report on federal mental health parity compliance. That report indicates that there is non-compliance from insurers in using standards of care that are not appropriate. And I think that from what I remember of this bill, there was an intent to have some of this potentially prior reviewed or reviewed on some level to make sure that it was appropriate. Maybe not prior, but like that there was eyes on what was being used, if I remember correctly. And so while I understand, Dan, your comments and others about the copyright piece and other pieces, I think that, you know, one of the things that my office is responsible for is seeing if, you know, if we can get access to those documents as regulators, and see if we can, you know, talk to, you know, whoever is providing that material. But it's really up to the carriers to let us know what's being used so we can determine if it's appropriate. And, you know, frankly, I think I'm concerned if, you know, I'm hearing that there are such, you know, strong copyright concerns about this information, that there may be information that wouldn't be accessible to the consumer. And that does raise some potential questions about what is being used. And I may have misheard that piece, and so I apologize if I did, but I just wanted to say, like, there I think was an intent to see this information and for carriers to demonstrate that standards of care were appropriate. And based on the recent federal report, I think we need to take a strong look into this.
Great. Thank you, Tasha. I see Jen and Dan both have their hand raised, so let's start with Jen.
Thank you, Jen Baker, Providence Health Plan. And I just want to, to follow up with that, like, I think, we don't necessarily, I didn't really understand the copyright until Dan explained it. So I appreciate that. But at the same, so we don't really have a copyright concern or a release concern. We're above the board and we are open and transparent with our standards and our guidelines. But I want to reiterate the focus on parity. And I'm curious, Tasha, if you can cite any similar standards or requirements on the medical side that you would reference before creating this new mandated requirement, because I want to keep that focus, right? So it's, we're not going beyond parity or creating new standards that aren't in the plain text of the statute.
Thanks, Jen. Dan.
So to address Tasha's comments, hopefully I remember them correctly. One is, I have no concern with submitting our criteria to the division. I have that could be part of the annual reporting. Another piece that is relevant is the requirement for us to complete this intensive NQTL analysis, where this is one of the things that we are required to analyze. Another thing that can be a red flag for for potential non-compliance with that is overturn rates. So if a plan has particularly higher overturn rates for behavioral health than for medical, that could be a sign that the standards may not be, commensurate with the community standard of care. Really, where and again, the copyright, I just want to emphasize, that's not a concern about transparency. That's just a concern about maintaining, not violating our contracts. Happy to share all of that information to the any of the ones that we've developed. As I've said, we can share and we will share upon request. So just wanted to emphasize that the goal really is not to get in the way of transparency.
Right. Thank you, Dan. And Gary.
Yeah, just clarify, do you know, or does anyone know if there's any issues with copyright or release information from those societies or associations we talked about earlier? Is it just MCG that may be giving us the challenge? Because I wonder if there's one, great, and if the rest of them don't have a problem, then we can.
I would expect that your call would probably be the same.
So can I just kind of cut in at that comment? I think on that note, and if these are with your contracts with third parties that you are using, I think that we should have a conversation, offline. There is a requirement or kind of under the TPA laws, and if you're using a third party, if there are provisions in your contract with the third party that do not allow you to comply with Oregon law, that doesn't get you out of providing that information. What that means is that either as carriers, you need to go to that third party and say, hey, we have a new law in Oregon. We need your help finding a way to meet this requirement. And I'm happy as a regulator to be on that call with you all, or to help make those connections. But the second piece of that is if we do have, or if there are particular entities that are barriers that are important for functioning, I think that that's another opportunity for us to step in as regulators and say, how can we have access to that information in a way that ensures that we can check compliance moving forward. So Thanks, and I'm going to go back on mute.
Thank you, Tasha. And Melissa, I see your hands up.
Yeah, and just also relevant to this section is the use of third-party companies and insurers contracting with them. You know, we at OIMHE, we have a concern particularly about Change Healthcare, which we brought up in our memo from December 3rd. So we submitted that before the December RAC meeting, but we would like to direct your attention back to that because we feel like there's information in that memo that is relevant to this discussion. You know, the concern being, you know, that that we have a third-party company working right now in Oregon and that is engaging in some practices that we find pretty questionable, that seem designed to, you know, change billing practices and that are focused on billing and reference billing rather than standards of care, rather than, you know, evidence-based clinical standards of care. And that's, you know, we want to make sure that those situations are addressed, and that if insurers are going to contract with these third-party companies, that they are being monitored to make sure that what they're doing is in compliance. And so we definitely have concerns specifically with Change Healthcare. There may be others.
Great. Thank you, Melissa. All right, we're running at about time for this conversation. So
can I just back up really quick? I just wanted to kind of just chime in and say, I think what, you know, this is just Dan's proposal to perhaps maybe add these this submission to our NQTL report is something that maybe I think that would address, you know, what Tasha was talking about. I think that might be an idea. I'm just open to it, and I thought, you know, throw it out there, something that would address what Tasha was talking about, but then also you know, not violate any copyright infringement. I mean, I know they're already referenced in those reports already, so as part of the parity submission. So
yeah, thank you, Jen. That's a great suggestion. All right, so before moving on, is there anything else that we should be thinking about in terms of rulemaking for Section 8? Does anybody have any last thoughts on this section?
I do, and it's actually a fairly significant one, and hoping maybe some of the other people on the committee can help out with this. So when this legislation was introduced, as I recall, the vision regarding levels of care was that system-wide we would all be using, you know, Locus, CalLocus, CASI, ASAM, including providers, CCOs, and commercial carriers. And the intent was not only to prohibit us carriers from having standards that were more restrictive than all of that, but also that everybody's using, you know, the same tool, speaking the same language. If we disagree, we can look sort of apples to apples at where we disagree. Somewhere in the legislative process, the requirement for CCOs was removed. And the providers, particularly the providers who offer higher levels of care, really weren't included in the conversation. My understanding of CASI and Locus and CalLocus is pretty limited, but I believe it's intended to be completed by somebody who has had direct contact with the patient and or the patient's support system, which would be the provider. And I do have a concern about if carriers are required to use these tools and the providers aren't using them, that we don't necessarily have access to the firsthand information that allows us to complete them appropriately. And I also don't think this would be a particularly good time to put a new requirement on providers. But typically, what we would do in a situation where we're required to use a particular set of tools is like, okay, well, this is the information you need to give us in order for us to approve this request. And I don't want to go out and say to providers, well, we're going to require you to complete the CalLocus CASI, because I don't think they're equipped to do it. But then that puts us in a position of not necessarily having the appropriate information or perspective or contact with the patient and their family to complete that appropriately. And so I just wanted to throw that out there and say, I don't object to using these tools, but I am concerned about how this may play out in terms of our system of care, and see if other people have ideas about how that may work operationally, or recommendations about kind of how to manage that possible mismatch.
Thanks, Dan. Are there other thoughts about that particular topic? All right, I'm not hearing anything. So Dan, maybe that's a conversation you can take offline individually, or we can have it individually as well.
Yeah,
Are
thanks.
Are there any other? Go ahead.
Oh yeah, I've reached out to various folks to try and get some perspectives on this. I don't have anything definite at this point, but I just wanted to put that out there.
Thank you. Go ahead, Gary.
Yeah, I side with Dan. I have a little concern and I hadn't thought about it, the providers aren't ready to use these tools, whatever they may be, to establish standards. That would be a little concern, because it's, if the larger medical groups are ready and the independents aren't, I mean, it would help if, anyone from representing the providers could speak to that, because I really haven't dove into that or thought about that. That was going to be a challenge. Because if they can't, then we'd have to come up with an alternative.
Thanks, Gary. Is anybody seeing that currently? Is there a feeling that providers are not ready to use these tools, or is that? All right, I'm not hearing anything. All right, so in the interest of time, I'm going to move us to the next item in our agenda. If there are additional comments or concerns about anything in this section, please feel free to send them as comments via email to either myself or Cassie. We do review all of those and take them into consideration and find them really helpful. So any additional comments on this section, go ahead and send them along. So next, Lisa Emerson is going to lead us through a discussion on section 6, which deals with network adequacy. Lisa?
Yeah, hi everybody. So I've been trying to focus on the network adequacy references in the bill, and kind of start the conversation with you all to find out if we need to provide clarity or further clarity to the references in rule. The division, DCBS already has network adequacy rules and has a statutory authority under 743B. 0.505 to establish standards for provider networks. So it on the onset of looking at these references to network adequacy in the bill, it doesn't jump out to making sense to me to have separate network adequacy rules for behavioral health versus medical surgical. So the rules for network adequacy are in 836.053 0300 to 0350. And so I'm not going to be pulling those up today. There's going to be maybe a request for a little homework and feedback on looking at the bill where we've had these references to network adequacy, and then getting your feedback of whether that needs to be clarified in rule. Should it be a standalone rule that's tied to behavioral health rules, or should it be considered to just being added to the division's network adequacy rules? So I also noted, Brooke, and all of you could help me out, that there's also a reference in section 5, subsections 2E on page 7 that I kind of wanted to start with. And then we kind of go on to section 6. So yeah, it's on page 7, section 5, 2E.
Okay, so page 7
7
of this
of the bill.
particular document. Okay.
Yeah.
Okay. And okay, where is this now?
Section 5,
Section
2E, little e.
Okay, am I in section 5? Okay, section 5.
Yep, there you
And
go.
then
So keep scrolling. And
then you
next
said
page.
section 2.
Yep, it's on page 7, Karen. So
It's on page 7.
All right.
If you keep going
That's okay.
down.
Okay, here's little b.
That's
keep
the bottom
going.
of the page.
Here we go.
Okay.
There it is.
Oh.
So right here, little e, sub e.
Okay. All right.
I'll go ahead and read it to you, or you can read it yourself. But this reference is specific to that there be a plan shall have a network of providers of behavioral health treatment sufficient to meet the standards described in ORS 743B.505 if there is no in-network provider qualified to timely deliver, as defined by rule, medically necessary behavioral treatment to an insured in a geographic area. The group health insurer or issuer of an individual health benefit plan shall provide coverage out of network, medically necessary behavioral health treatment without any additional out-of-pocket costs if provided by an available out-of-network provider that enters into an agreement with an insurer to be reimbursed at in-network rates. I'm just wanting to put that out to the group, whether that would benefit from further clarification in rule, or is what is stated here sufficient in the law? And I see a hand up. I think is that Rachel?
Yes,
Yeah.
thanks so much. I haven't looked at the MedSurg network adequacy, so apologies if it's a very
That's
quick
okay.
answer. But I guess my question is whether or not the language timely deliver is defined in that portion of network adequacy. Because if so, then I just need to dive into it. And if not, I'd like to have a conversation about that.
Yeah, and so I think it will be helpful to look at the standards that are the national standards that are explained in rule, and that is in 836.053.0330, and it refers to the Medicare Advantage standards that are being used as the division using it as the national standard, and there could be further standards that come out from also from the feds, from CMS, regarding qualified health plans, so individual plans, a small group. So the division is going to be looking at network adequacy rules more broadly in the coming year. So I think that references to network adequacy for behavioral health seem as though they would fit well with the general network adequacy rules, but we could clarify, again, law that's called out here in rule if it would provide greater clarity. And so that will be some additional homework we need to do that will help us as the rule making team develop draft rules for that. So I will get the references out to you specifically of the rules to take a look at, to compare with the bill, and we'll continue to do ongoing work on this. I see some other hands up. I'm not sure whose hand up was up first, but I can see Gary's hand up.
Yeah, just clarify. So in this sub E, are you saying that, as long as that out-of-network provider enters into agreement with the insurer, there's no, balance billing, but if there's not an agreement entered into between the insurer and the out-of-network provider, the member can be balance billed. That's how I'm reading it. Just want to confirm.
I believe so. There is a
Okay.
Okay, we have an echo. I'm sorry. There is another reference that an individual, an insured can see an out-of-network provider and be balanced billed if there isn't an agreement. I can't recall where I saw that reference that it says this section does not ... I'd have to find that section and get back to you on that. Does anybody who was involved in development of these of the bill, the language in the bill, have any clarity they can provide on that question for Gary and me and everybody?
Hey, Gary, this language came specifically from my client going back to 2021, and that headspace is a little difficult at the moment, so I'll check back with them and get you something in writing.
Okay, just wanted to make sure I was reading it correctly.
Of course.
Okay, I see another hand is raised, but it's down the list here.
I think it's me. This is Chris
Okay.
Bonnet with NAMI. I just wanted to express NAMI's general concern around this area is that all the stuff that we supported in terms of network adequacy had to do with the significant disparity in us having to access out-of-network providers because in-network is not available to us. So when Milliman put out all 2 sets of reports on that, the disparity between medical, surgical, out-of-network access and behavioral health was significant. And so trying to crack that nut is our ultimate aim out of all of this. And in DIS, one of the things that, because in-network isn't available, we're on our own seeking often out-of-network. And so it's becomes us acting as our own care coordinators, even just trying to find a provider to take us.
Okay, thank you. Any other thoughts on this particular sub-paragraph? Melissa?
Yeah, this is just as a provider who has worked out of network with an insurer, there's this piece about the agreement. I just want to point out that I have come up, had an agreement with an insurer before to take a particular amount from them that I believe was higher than their in-network rate, but lower than my full fee. So that can also happen. Sometimes you can come to a negotiated agreement, which is sort of meeting in the middle, and that does happen. So the provider doesn't necessarily have to agree to take the in-network rate, but could agree to another negotiated amount.
Thank you for that explanation. So I think, more time needs to be taken to look into this and see where it could be given some clarity in rule. Just wanted to, gather as much input and thought from all of you beforehand before jumping into that. There are other references, again, to that refers regularly to standards adopted or established by DCBS. So there is the authority to establish network adequacy standards. And I just feel like a lot of these references, while they are in the law, can be further clarified if needed in those rules. So I guess that is some homework that we're going to need some help with from the RAC to take a look at the current network adequacy rules and what's stated in the bill and see where we can provide more clarity to help address some of these problems and issues.
Lisa?
Yeah.
Yeah, it's Jen Baker again. I just wanted to say, well, you think this language is fine. And Tasha's probably gonna shake her head at me, but my only request is that you don't, create new rules here and then open up the other side of the network adequacy rulemaking, create new rules there that then conflict, and then we have to come back in and change. So keep things consistent, keep things, or don't touch it at this point and wait and see what they want to, what the DFR is going to do with the broader network adequacy requirements, because we just want it to be clear what the expectation and the standard is, as opposed to just bouncing around. But, again, we find this language very clear as it stands. So, I mean, we'd be fine with it the way it is. But if you are going to change it, let's wait and see what they do with the other network adequacy requirements.
Thank you for that input. So are there any other sections we should take a look at this time, Brooke, or should we organize and think about the homework assignment that we need some help with, and then put that out to the group?
I think if you think the conversation was sufficient, we can organize the homework assignment and send that out to the group. Do you have thoughts about a deadline for that, since our next RAC meeting is in 2 weeks? Is that a discussion you want to have at the next RAC, or do you want to push it back, Lisa?
I'd like to have it. I think we can, continue the conversation, but continue to make progress. And so if the group can just have some initial thoughts, they don't have to be fully formed, but I would like to go ahead and have that conversation at the next RAC, if that works for everybody. And I'll try to get something out quickly so you have enough time. Yes.
Let's see, Laura.
Go ahead.
Hi, Lisa. Thank you. I just wanted to clarify because some of the comments that Basic Rights Oregon submitted were specific to the list of specific groups for which the department would have to ensure that a network has an adequate number of providers to serve those specific groups. Is that something that you see as a part of this, broader conversation of network adequacy, or would those remain specific to behavioral health? I just wanted to know if you were contemplating that section in this.
I am contemplating that. Thank you for reminding me about that comment, because I did see the comment and I made a note of it that our medically underserved enrollees clearly defined in rule. And that is referred to in rule. It's not necessarily calling out specific populations, but it doesn't look like it couldn't be done in the current network adequacy rules. So I have flagged that, it be as other groups. So section 6 for B in the bill, it says other groups specified by the department by rule, like you mentioned. And I think that is something that could be spelled out for LGBTQSIA+. But it's kind of generally referred to in the current rules. So I think that applies broadly, behavioral health and medical surgical. So I've got that down to.
Lisa, I would agree with what you just said, just FYI. And
okay.
we do know that the DFR is very focused on network adequacy and cultural competency. We just had a conversation this morning with the commissioner on it, and it's something that Providence is very serious about and wants to be proactive on. So, I mean, we're open to ideas on that, but like that's, so again, I think it's part of the broader conversation, both MedSurg and behavioral health.
Thank you. Any other comments or questions right now on the topic of network adequacy that comes to mind that you want to flag for us? All right, well, I'll be sure to get those rules out to you to take a look at. Thank you for your feedback today.
All right, thank you, Lisa. So next we have Tasha, who's going to give an update on the reporting that's due on April 1st, which is only a couple days away, surprisingly.
Hey, everybody. So not much of an update because, as Brooke said, the report isn't actually due until the end of this week. We have started talking with our insurers and had a little bit of outreach around how to submit the report and potential extensions for one insurer. However, I think everything is on track. We also are getting the positions filled for the people who will be who we will be using to staff up for this, and they are going to be engaging in training in the coming weeks as well if they need it. But that is, I'm hoping to get them on by the end of April. So we're hoping to have all the reports reviewed 60 days from that point with some feedback after that. So that's where we're at this time. Does anybody have any questions? Okay. That is all.
All right, thanks, Tasha. So we have about 20 minutes left, 23 minutes left. Does anybody have any last additional comments, or should I move on to next steps? All right.
Brooke, are you taking comments from non-advisory committee members by chance?
Yes, thank you for that reminder. Lisa just reminded me as well. So I would like to take a moment to open it up to any comments from the public, any comments from non-advisory members. If anybody has any, please raise your hand. And Rick, go ahead.
Thanks, everyone. Rick Blackwell from Pacific Source. Just a few things as I was listening to the conversation. First, when it comes to standards that an agency adopts by rule, you've got to be very specific about the version of the standard that you are adopting so as to avoid unnecessary or unconstitutional delegations of authority to an outside party. There's a whole line of Oregon cases about delegation in the rulemaking context. And so I just invite the department to be as specific as possible if it does choose to adopt a standard. I can pull up, I have got one case site open right now if you'd like it, but otherwise I think just look in your AG law manual, it's right there. On the copyright matter, I'm not a copyright, I did middling at best in intellectual property, but I do want to suggest that the issue with copyright could be that if we are to have a standard that's an outside standard, say from a professional society, and the terms of the licensing agreement don't allow us to publish those standards, or it's less than a full publication, then we might be in a position where you've got an infringement suit on one side and an insurance code action on the other side, depending on how we act in a circumstance. So I think it really is incumbent on us to figure out whether or not professional societies or others that have these standards in place are going to allow what levels of publication are going to be allowed so that we don't have copyright infringement claims. And finally, Lisa, to the point on the rulemaking, I think just given the way that that's drafted, I think that the department's limited to figuring out what timely deliver means under rule. And so maybe we can just keep that discussion as narrow as possible. So those would be my comments, and thank you.
Thank you.
Thank you, Rick. Does anybody else have any other non-members of the advisory committee have any comments at this time? If so, please raise your hand. Right, hearing none. So the next steps, we do have the next RAC meeting on April 14th from 9 to 10:30. That is just 2 weeks away. So the plan for that meeting will be to have a conversation on the homework assignment that Lisa is going to send you regarding network adequacy and our current rules, and then to have some kind of at least brief draft, or if not a draft, an outline to share with you so that we can start actually digging into what the rules may look like. That's a tight timeline for Lisa and I, but we'll do our best to get something out to you guys. So are there any other thoughts before we sign off? Great. Well, thank you everyone for the conversation. I really appreciate it, and have a nice day.
Thank you.
Thank you.
Thank you.